Okay, so I'll be next over 15-20 minutes. I'll be speaking on evolving role of immunotherapy in early stage, small cell lung cancer. Sorry, it's for. Can we go to the next slide? Extensive stage small cell lung cancer is where I'll be speaking over the next 15-20 minutes. So we know that lung cancer is the leading cause of cancer-related deaths worldwide, and small cell lung cancer represents almost 15% of these all lung cancer cases. So though many times in a clinical practice, we tend to ignore small cell, but then small cell is the one. In fact, when we are looking at cases in non-small cell lung cancer, we are even looking at 1% and 5% bracket of ALK MET. We should also have a important knowledge of how to best manage the small cell variety, because most of these patients, in fact, they come to us when they are already advanced. So extensive stage small cell lung cancer is the usual presentation which patients come with. Also, we have this presentation where we'll have at least 50% of these patients would have either asymptomatic or symptomatic brain metastasis at presentation. Most of these patients are elderly and they are heavy smokers. So these are the baseline characteristics which with these patients present to us. Next slide. It also known that approximately 2 out of 3 patients with extensive stage SCLC are diagnosed with expectancy which is less than a year. So by the time they come to us in the clinic, they're diagnosed, they would often have a dismal prognosis. So as a clinician, we really face the challenge as to how to prognosticate these patients. Whereas we have a patient who is ALK positive or EGFR positive, we really feel happy that these patients would be treated with pills. On the other spectrum, we have a lung cancer patient who could actually not even survive a year, and the 3-year survivors have been dismal as 5%, and 5-year survivors have been almost none, 1 to 3%. Next slide. So that has been the scenario for more than 5 decades, and there's been not much change except for cisplatin and etoposide, which first came the standard of care as in 1985, and after that we had some second-line drugs like topotecan or the camptothecin family, and then most of the drugs had failed. There was some success with nivolumab in this post multiple lines of treatment, and then there was hardly any progress for 30 years. Over the last 5 years, we have had 2 standards of care which have come up in 2018 and 19, which are a combination of PD-1 inhibitor along with the standard of care, which was platinum with the etoposide. Next slide. Next slide. So as of now, we have in 2022, the first line treatment is a combination of a platinum-based doublet along with etoposide, prophylactic renal irradiation and radiotherapy at physician's discretion, and the drug combination. So that has been one of the standard of cares, but then we also have first line NCCN category 1 approval for either Imfinzi plus EP or Atizo plus EP as a choices for these subset of patients. And that's over the next 7-10 minutes, I'll exactly let you know why these are the preferred compared to only an EP based combination. So once we go for an EP based combination, we have 2 choices. If the patient relapses more than 6 months, we could actually have a platinum rechallenge, or we could also offer a non-platinum therapy. But if the patient relapses in less than 6 months, definitely we have to go to a non-platinum therapy, either in the form of topotecan or this lurbinectedin or clinical trial. So these are the current options. We hardly have any options in the second line or beyond. Next slide. Next slide. So this is a cartoon which depicts the journey of a patient. So if a patient is diagnosed in the first line as an extensive stage small cell lung cancer, then 60 to 70% patients will typically respond to a platinum-based doublet, but then the response is short-lived. Most patients will not respond beyond 5 to 6 months, and resulting in poor overall survival rates. The median OS is 7 to 12 months, and OS at 1 year is around 40%. Next slide. And if you just see the number of patients who are eligible for second line treatment are around 30 to 50%, and beyond second line, less than 20% patients are actually eligible or they are physically fit to get a third line treatment. So with each subsequent treatment, the number of patients who could benefit from the subsequent line become much lesser. Next slide. And this shows that the first line has to be the best line in small cell lung cancer. Otherwise, beyond first line, the number of patients who will become eligible for second or third line are dismally low. So now coming to the data with the Atizo. So if you just see, even with Atizo, if we just start with the first line, the objective response rate is 60.2%. And again, the progression-free survival for Atizo plus a platinum-based doublet is only 5.2 months. And long-term survival has been not been demonstrated. If you just see, the curves slightly separate. So the curves are separated at 12 months, and by 24 months, they again are merging together. That means that 2-year OS is quite similar in both the arms. So whatever benefit is gained is over the first year only. Next slide. So if we think of these patients, then at 2 years we don't have any survival benefit in the patients who are given Atezo along with a platinum and the platinum here uses only etoposide carboplatin. So we don't have a survival benefit at 2 years or beyond with the Atezo based EP combination. Next slide. Now, if we come to the Caspian data, because there was a landmark trial, and this was the first and the only approved IO regimen in extensive stage small cell lung cancer to allow up to 6 cycles of EP in the control arm and use of cisplatin or carboplatin. So if we just compare this to the Atezo study, so in the Caspian study, if you found that the patients actually in the comparator arm could be offered 6 cycles of any platinum, cisplatin or carboplatin. The patients had to be also, they could include patients with brain metastasis, and up to 6 cycles of chemotherapy were allowed in both the arms, and PCI was also allowed in both the arms. So if you just see, the kind of trial design of this was much better than compared to the Atezo trial. So even with all these inclusions in the study, if you just see, the primary endpoint was overall survival. That was a real good endpoint, and the key secondary endpoints were PFS, OS at 18 months, and objective response rate apart from PFS and quality of life. So all these patients, it was a large trial, 805 patients randomized 1:1:1 to 3 arms. The first one is the Imfinzi plus EP arm, and the second was only EP, and the third was actually stopped because of the non-function of this arm. So the first and second arms were important. So I'll just look at the data in the next arm. Next slide. Next slide, please. So if we just compare the IMPA 133, which was the Atezo trial, carboplatin was only allowed and cisplatin was not allowed. Patients with brain metastasis were excluded, and only 4 cycles of EP were allowed in both the arms, and which is less, I would say, related to the real world use of the EP. We normally use 6 cycles in most of our fit patients, whereas in Caspian we found that cisplatin or carboplatin, based upon the patient's fitness, was allowed. Up to 6 cycles were allowed, and asymptomatic, untreated or treated brain mets both were eligible to be a part of the trial. Next slide, please. Imfinzi plus EP is the first and only approved IO to demonstrate a statistically significant and sustained improvement in the OS and versus the EP arm at 12, 24, and 36 months. And if you just see the arms which are the investigation versus the standard of care arm, the separation was 52.8% versus 39.3%, and at 18 months was again higher, 32% versus 24.8%, and 22.9% versus 13.9%, and also at 36 months, that is at 3 years also, the patients surviving were 3 times higher, for 17.6% versus 5.8%, and that is what is the beauty of this. If you just see the trial here, really, I would say, real world data kind of a study, and having a sustained and a prolonged benefit in a subset of patients, even at a follow-up of 3 years. Next slide. And this is what is evident in both the, you can just see comparatively the IM power 133 versus the Caspian 3. You can make a difference that the separation of curves does not get say at the same level at 24 months in the IMPA 133, whereas it continues to be separated and have a survival benefit at even at 3 years in the Caspian data. Next slide, please. Also, if you just see the overall survival rates, the first year are comparable, the second years are also comparable, but by the third year, the Atezo arm fizzle out, and then they didn't have any reported OS data, whereas in the 3 years OS data was 17.6% in the Caspian study. Next slide. If you just see the various across the various subgroups, the Imfinzi arm had a better hazard ratio across all the age or the sexes, performance status, smoking status. Even in brain metastasis, the number of patients in the brain metastasis were less, but then the hazard ratios were favoring the combination of Imfinzi plus EP versus only EP alone. Next slide. Also, if we just see that the objective response rates were much higher. So even at 24 months, the objective response rates were 67.9% versus 58% in the Imfinzi arm compared to only EP arm. And the duration of response at 24 months was also much higher. So it was in the responding patients continued to respond better, and the response rates were quite higher in the responding patients. There was more than 3 times patients who were remaining in response in the Imfinzi arm compared to only EP arm. Next slide. And so the impression is that the patients who kept responding continued to respond at 12 months, 18 months, and 24 months in the patients who were in the Imfinzi arm compared to only EP arm. Next slide. So the OS based on the baseline brain metastasis, again, patients irrespective of their brain metastasis status, both the patients without brain metastasis and as with also with brain metastasis has had a continuous improvement in the median overall survival. So if you just see a patient with brain metastasis had an OS of 12 months versus 8.8 months, and without brain metastasis had a difference of 13 months versus 10.5 months in the Imfinzi arm compared to the standard comparator arm. Next slide. Again, with respect to the all cause adverse events, the Imfinzi arm the rates of grade 3, grade 4 adverse events were numerically lower in the Imfinzi EP arm compared to only EP, and there were nominal differences in discontinuation rates due to adverse events in the either arm, and immune-related adverse events were higher in the Imfinzi arm compared to the EP, and that is known and most common was thyroid-related events, and majority of immune-related adverse events are low grade and managed with in lines with standard treatment guidelines. So the addition of Imfinzi to EP was quite manageable with no major increase in chemotherapy-related side effects. There were some adverse events related to immune relations, and they were managed with standard treatment guidelines. Next slide. So again, if you just see the rates of febrile neutropenia, pneumonia, anemia, thrombocytopenia, you could just see that they were in fact lower. Many of them were actually lower in the Imfinzi EP arm compared to only EP arm. Next slide, please. Also, with respect to all the quality of life as well as cognitive, emotional, physical, and role functioning, all favored the Imfinzi plus EP arm. So the quality of life was well maintained. In fact, doing much better in the Imfinzi plus EP arm compared to only EP. Next slide. So with respect to the side effects, you can just also say that time to symptom duration from the baseline also were much better in the Imfinzi plus EP arm only compared to the EP arm. Next slide, please. So the Caspian demonstrated Imfinzi could be administered every 3 weekly with EP and Q4 weekly as a maintenance. So with chemotherapy, it was given 3 weekly, and after that it was given 4 weekly. It was very convenient for these patients to follow up with the maintenance dose of Imfinzi vis-a-vis Atizo. Next slide. So if we just see, the most important thing was if we just compare to IM power 133, brain metastasis was not allowed, and PCI was allowed, and up to 6 cycles were allowed, and cisplatin was allowed. So and one more thing which was important was that PCI was excluded in the experimental arm, and in fact most patients could do well without PCI in the Caspian study compared to IMP 133. So the patients were allowed treatment either with cis or carboplatin. It include patients who are having asymptomatic or untreated patients with brain metastasis, and were compared to given 6 cycles with the optional PCI. Next slide. Next slide. And that's what brings us to the NCCN guidelines, and they have approved this as the category 1 recommendation and one of the options for our patients. But based upon these data, the clinicians have to decide which are the better combinations to be given in the first line setting. Next slide. So to conclude, first line durvalumab EP has shown sustained and improvement in OS compared to robust control arm that is reflective of the real world scenario, allowing up to 6 cycles of EP with the use of PCI as compared to the results with atezo and carbo-etoposide. And durvalumab is the only IO that has flexibility for choosing cisplatin or carboplatin along with etoposide, and benefits of durvalumab EP were observed across all subgroups, including brain metastasis. More than 17% of patients with durvalumab EP were surviving at 3 years, showing almost triple the survival benefit compared to the comparator arm. And durvalumab offers convenient once monthly dosing for maintenance phase, and safety findings were consistent with known safety profile of durvalumab plus EP. Thank you so much.
Thank you, Dr. Sajjan. So that was really a nice. So, so what is your combination chemotherapy with durvalumab? So, do you prefer using cisplatin or carboplatin? And second question, what is the current status of PCI and chest irradiation after we have atezolizumab or durvalumab in our armamentarium along with chemotherapy in extensive stage small cell lung cancer?
So if a patient is less than 65 years, no major comorbidities, I prefer cisplatin. Beyond 65, I go for carboplatin. I offer them, I begin with in my mind of having 6 cycles, but if the patient is doing well, then I might just end up at 4 cycles and continue durvalumab based upon case-to-case basis. PCI I have been avoiding in my patients because of the cognitive deterioration with the PCI. I would like to reserve it later, especially the patient doing well. And yes, consolidation to the local site, it has responded really well. I am doing for my patients.
So, sir, with consolidation, immunotherapy along with the consolidation radiation. So, I think is it toxic enough? Is it tolerated well?
Yeah. So again, it depends upon what kind of a response the patient has got. I would say the patient only got the extra pulmonary disease is not much. The patient has responded very well, and the field which the patient has to be rated is not that big. Then yes, I would go. Otherwise, I'll have reservations for use of radiation. I'll continue only durvalumab in such patients.
Right. So I think we have trials which have compared just the observation vis-a-vis MRI brain every 2 to 3 months, and you can safely avoid PCI for patients if they understand that they can be well kept under observation along with MRI. Sir, your experience with atezo or durvalumab in this setting, sir?
Sorry, I lost your connection, Manish.
Sir, your any experience with this atezo or durvalumab in this setting, sir? Any patients?
So I've been using durvalumab as my preferred combination for such patients.
Okay, sir. So the toxicity and the tolerability is okay, right?
So I would say that does not really have major difference, but though some patients, 5-10% patients do have thyroid disorder abnormalities. Otherwise, the combination is well tolerated.
Sir, I think few of my patients have this combination, and fatigue is one of the issues which I frequently encounter with this with treatment. With extreme fatigue, I have observed that the patient have when they are given chemotherapy along with immunotherapy. One of my observations.
I agree with you.
Thank you so much, sir.